Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our conversation with Cancer Expert series, we have one of the leading leukemia experts in the United States, Dr. Daniel Pollyea, who is chief of the division of hematology at University of Colorado and a renowned leukemia researcher. So, welcome, Dan.
Well, thanks, Ravi, for having me. And as we were just talking about before, it's so exciting to connect with you, given all the work that you and I did years ago in this field. And you're definitely somebody I've always, continued to really look up to. So really appreciate you having me for this.
Thank you for those kind words. So what we're going to talk about is about FLT3 inhibitors. So just let's get started. First for the audience, how common is FLT3 mutation?
Yeah, FLT3 is amongst the most commonly mutated genes in AML. I mean, upwards of a third of patients will have a FLT3 mutation that usually skews a bit younger, and is associated with more proliferative disease that has more aggressive features. But it is one of the most common genes mutated in AML.
So is it a mutation that occurs very early in the evolution? Is it a late mutation? How do you describe it?
Yeah, we typically think of the FLT3-ITD, so it's important to remember there's two main types of FLT3 mutations. There's the FLT3-ITD, which we're mostly talking about here, has a negative prognostic significance historically, causes proliferative disease. And then there's another mutation that can occur in the tyrosine kinase domain of the gene. So when we're talking about the ITD FLT3 mutation, we typically think that that's a late mutation. So that's something that occurs later on in the development of the disease. And it's also can be kind of what we say promiscuous. It can be a mutation that is present, let's say, at diagnosis or not present at diagnosis, but comes on at relapse. So it's an important one to always be looking for, even if it wasn't present at the beginning.
And you sort of hinted at this about the two different kinds of abnormalities we can find in the FLT3 receptor. Could you just give us an idea of how common and what the implications may be?
Yeah, so the more common is the FLT3-ITD, and that can occur in this juxtamembrane domain. And there's this insertion that can be upwards of many dozens of additional base pairs, and that accounts for the majority of the FLT3 mutations. About 5 to 10% of the time, you'll have a point mutation in the tyrosine kinase domain. The prognostic significance of these is somewhat different, we think. And so, the FLT3-ITD certainly has a poor prognostic significance. The TKD mutation, probably not as historically bad of a prognostic significance, but maybe still worse than not having a FLT3 mutation altogether. So it's important to kind of appreciate these differences. And the exciting thing, Ravi, is that I think with the advent of some of these FLT3 inhibitors, the prognostic significance of all of these might be changing. So that's kind of something we're seeing being worked out in real time here.
So it is prognostic, as you said. Does transplant overcome the adverse prognostic impact?
Yeah, I think it can. And, certainly in like certain individual circumstances, that is the thing to do. Historically, we've said that anyone who is a candidate for a transplant who has a FLT3-ITD mutation should get a transplant in first remission. And, I think this helps. Historically, this was helpful. But these patients still suffered from additional relapses and worse survival. And so it was something that was necessary to do, but it wasn't always curative. So I mean, I think it's really interesting seeing how this is changing now with some of these really effective FLT3 inhibitors. there's some question and the ability to measure the disease at very, very low levels. I think there's some reasonable questions emerging now as to whether there are some subsets of FLT3 mutated patients that may not need a transplant or may be able to be cured without that. So, interesting question kind of going on right now, but historically, very, very clear that the path was to transplant was the ideal circumstance.
So along those lines, you say that not all FLT3 may be as bad. So does the frequency of the mutation matter?
Yeah, so historically, there's been some data that when you have a FLT3 ITD with a high allelic ratio, so more disease burden with the FLT3, you can think of it as those patients did worse, and typically that was measured with respect to survival, not really so much with respect to remission rates, but more on the survival side of things. Those patients did worse. And that was an important consideration. Now, some places maybe went as far as to say that if you had a lower allele ratio, you may not need a transplant. There were some discussions about those types of considerations. But again, now with MRD capacity being capabilities being what it is, and our ability to monitor this disease at such a low level, it may not be as important anymore to sort of try to prognosticate the implications of FLT3 allele ratio at diagnosis, and instead just get patients into remission and then measure how deep the remission was.
So I guess that reflects somewhat in the recent, not too recent now, it's been a few years since the ELN risk classification was revised.
Yeah, it's pretty amazing, and this is kind of what this is what progress looks like in the field. I think, back in 2017, sort of before the widespread advent of FLT3 inhibitors, having a FLT3 ITD, particularly with wild type NPM1, was an adverse risk profile. But then by 2022, that moved up into the intermediate risk category. And again, I think this has everything to do with the ability to target FLT3 with these really effective targeted therapies is able to kind of turn maybe what was historically a bad prognostic feature into something not so bad.
And this is prevalent in all risk categories of AML, or is it more prevalent in one specific subtype of AML?
Yeah, so I mean, I think, AML that has, let's say, some favorable risk factors, like a core binding factor AML, those are pretty unusual to have FLT3 mutations. In those rare occurrences that they happen, we tend to allow the more favorable risk features to be predominant and to kind of hope for the best there. APL, is one that quite commonly acquires a FLT3, but doesn't have any bad prognostic significance really once you effectively treat it with an APL-based regimen. And then, other disease biology subtypes like AML that evolves out of antecedent hematologic malignancies, they just don't have FLT3 as much. So, FLT3 is mostly like an intermediate, historically intermediate risk de novo AML, and that's really where the FLT3 mutation predominates.
And do we look for it at every stage along the journey for a patient? You sort of mentioned about it being promiscuous.
Yeah, I mean that is the challenge with FLT3 is that you can never assume it's not there, and so at every time you're restaging a patient, at any time you believe a patient may have relapsed, or certainly at diagnosis, you must test for this. Not only because of the prognostic significance, but now because of the availability of all these FLT3 inhibitors, which are available both upfront and at relapse, and the different ones. So it's really important to test at certainly at diagnosis, but then at suspected relapse as well.
And what are the techniques to detect the mutation?
Yeah, I mean, lots of really interesting new techniques that used to be just a standard PCR test that kind of took a long time to come back. But now there's much more sophisticated tests that can do this, like NGS tests. Those don't necessarily make the turnaround times any faster, but they're part of more comprehensive testing panels. But for the most part, this can be pretty easily and quickly detected just by old school PCR methods. Now, there are now very sophisticated deep sequencing techniques that can be used to help us understand how much residual disease is present in a patient in a remission, for instance. So there's some helpful detection techniques there around FLT3. And so that's kind of new and emerging, but those are commercially available as well.
So let's switch to therapeutics. So obviously, you hinted that for patients who are eligible, most would ultimately, if possible, go to an allogeneic transplant. But what about these new FLT3 inhibitors that you mentioned? Some of them have actually been around for a few years, so not exactly new. So how do you approach your frontline patient with a FLT3 mutation? Both in the patient who is eligible for intensive therapy and not.
Right. Yeah. So those are all the right kind of questions to be asking and the right caveats. So, the first thing is in a newly diagnosed patient who is eligible for intensive chemotherapy, in the presence of a FLT3-ITD mutation, you have two options. The sort of older option is midostaurin, and that's based on the RATIFY study that showed superiority in patients who received midostaurin. And then we also have this new option of quizartinib. Both of these resulted in a survival benefit versus a placebo. We don't have any data of these head to head. So, it comes down to kind of personal preference and, decisions about the side effect profiles of these drugs. But both of these are very reasonable options or recommended options for patients with a FLT3 ITD. If a patient has a FLT3 TKD, then that's not a patient that we would give quizartinib to. But if in the upfront setting that patient were to be eligible for intensive chemotherapy, that patient should get midostaurin. That's really the only option in that situation. Now, if a newly diagnosed patient um, is not a candidate for intensive chemotherapy, there's really no upfront FLT3 inhibitor that's FDA approved for use. Those are patients for whom most people would give a venetoclax-based regimen to, and there's no FLT3 inhibitor that's yet approved for use upfront with a venetoclax-based regimen, but there's certainly a lot of clinical trials looking at that, and I think that's the preferred way to go to look at a clinical trial for that situation. And then finally, in the setting of a relapsed AML, whether it's an ITD or a TKD, the only approved therapy there is gilteritinib. So that's approved as a single agent. It's an oral therapy for relapse refractory AML with a FLT3, ITD, or TKD.
And do you give maintenance therapy after an allogeneic transplant?
Great. Yeah. So, I mean, there's a lot of different practice patterns here. So, I think there was a recent clinical trial that was presented that was, supposed to clarify this a little bit. And it used gilteritinib. And the question was just that after an allo transplant, is there a role for gilteritinib as maintenance? And, at the end of the study, it was, a little bit messy. You could think of it as a negative study, but there was a subset of patients who were MRD positive in the post-transplant setting who really did benefit from gilteritinib maintenance. And so I think you can make a strong case that is, that is something to at least strongly consider. And NCCN, has some recommendations around that, even if it's not FDA approved per se. But that's the only one with strong data, and I would say that's the best scenario to consider that for.
And if you do use it, for how long would you use it?
Ooh, yeah. I mean, so, I think there's a variety of opinions here. Most people I see recommend somewhere between 1 and 2 years around that.
And now that we have a number of agents that have come into the armamentarium of AML treatment, we have menin inhibitors that have been recently approved. So if patients have more than one mutation, they have a FLT3 mutation and something that can be targeted by menin inhibitor like KMT2A or NPM1, how do you decide which one to go after?
Yeah, I mean, what a great place that we are when we have these options in AML, like, that we can even have this conversation. It's pretty amazing given, as you know well, where this field was, 10 or so years ago. Yeah, I mean, I don't think where there's any data to guide us. I think, you're right. Now we have IDH inhibitors, we have the FLT3 inhibitors. We now have menin inhibitors, so there are lots of different considerations. One way to play it is to say I'm gonna pick one target and sort of ride that out, try to get a remission for as long as possible, and then move on to the next one when the disease comes back or if it doesn't respond. I think that strategy makes sense if you're really trying to draw out your remission for as long as possible. Perhaps that's a patient who doesn't have a transplant option, for instance. Alternatively, if there's a patient that you really want to get that patient to transplant, you could justify, okay, they have two targets, we're going to give them both targeted therapies because I want really quickly or as quickly as possible to get this patient to respond, get a remission, and move on to transplant. So, I mean, I think I don't have the answer for which mutation you should go after first. I think, we all kind of have a lot of respect for the damage that a FLT3 mutation can do, and I think a lot of us would reach for that one first because of that concern. I don't know that that's always the right answer. I think that's what most people would default to if they had to pick one. That may be the most important driver mutation in the relapse setting, but it's a really kind of a good research question.
And does the what we call the variant allele frequency of a particular mutation guide you that if one is prevalent more, would you consider you targeting that first?
I think that's a great way to think about it. Yeah, I mean, to look at the report, the sequencing report, and try to pick the mutation with the highest allele frequency on the theory that that's driving the bulk of the disease. That would make a lot of sense. So, not necessarily what I've adopted as my practice, but a very reasonable thing to do.
So last question, what do you look forward to coming up? Is there anything on the horizon for these patients that you are awaiting data on?
I mean, I think for AML in general, you mentioned menin inhibitors, and I think moving menin inhibitors into the upfront setting, we can see how powerful that move was in the FLT3 positive space. When FLT3 inhibitors got moved into the frontline setting, we saw these dramatic survival benefits. So hopeful we might see something like that with menin inhibitors and moving them into the upfront setting. But then also, like I would say, with respect to FLT3, I think there's these subsets of FLT3 positive patients, particularly that co-occur with an NPM1, which is pretty common, where we might not need to transplant these patients, which is a very big deal and a very, very new would be an important finding. But I think, using MRD to guide that decision, but is going to be really important. But how exciting that there may be a subset of FLT3 positive patients that can be cured without a transplant. That was just unimaginable a few years ago. But I think it's in the cards right now.
Well, I want to thank you very much for taking the time to educate the audience about this evolving area. And I hope that I can turn to you in the future as the field evolves for more guidance.
I would love that. Thanks so much.
Thank you.